Every so often, a video is produced which combines innovation, surgical excellence, and humanity. It is a privilege to show you a video produced by Brazilian Dr. Claudio Trindade and his extraordinary family entitled In Despair.
Você não consegue usar a lente de contato e, no seu caso, a cirurgia de anel não melhorou a visão. Então, a última opção que temos é o transplante de córnea.
Aí começou a perceber na época de escola, né? Que aí a gente começa a ter dificuldade de enxergar o quadro, né? Aí desde 15 anos comecei a fazer a lente. Eu não faço um café sem a lente. É o que, né, me ajuda durante o dia, porque senão eu não conseguia fazer nada. Com a lente eu não consigo nadar, né, mergulhar, não tem como, né? Com a lente é muito limitado. É desesperador.
The purpose of this film is to present a new way of treating keratoconus. Clear lens extraction with an IOL implantation and a pinhole piggyback.
O anel não deu muita diferença, não.
Dá pra ver alguma ali?
A letra L.
Ali dá pra ver. Aqui ainda dá?
Não, muito embaçado. S-T-O-Z, mas tá embaçado. Agora eu tô vendo. É O-T-O-F-S. Tá ótimo, tá nítido.
This new approach is the perfect marriage between two treatments combined into one single procedure. Lens replacement is effective reducing ametropia, but is not enough. High-order aberrations must still be managed, and this is accomplished by the pinhole.
Tem 5 pontos aí que são muito favoráveis no seu caso. Quais são eles? O primeiro é que seu ceratocone está estável. O segundo é que a curvatura da córnea é menor do que 65. O terceiro é que a córnea é totalmente transparente. E além disso, a área cometida é uma área mais central. O quarto é que sua pupila é muito grande, o que acaba favorecendo a entrada das aberrações dentro do olho. E o quinto é que o comprimento do seu olho não é muito longo. Ou seja, a cirurgia está muito bem indicada no seu caso. So why this instead of DALK? Well, 2 reasons. We expect a better visual acuity than DALK, and overall we believe that it's safer and more predictable in the long run.
Aspiration of lens material is done through a 2.2mm incision. Capsular polishing is carefully performed. Then, the IOL is placed in the bag. With the help of an injector, the foldable pinhole is implanted, and in this case, is also placed inside the capsular bag, together with the IOL.
E aí, como que tá? Tá o quê?
Tá enxergando.
Tá enxergando? Se eu tampo aqui, ó, você consegue ver as letrinhas lá? E esse aqui?
Não.
Não?
Não.
Tá melhor do que o outro?
Nossa.
Muito melhor.
tá bem?
Tô bem, tá demais.
Tá bem?
Tô.
E ali?
T-E-Z-R-S.
In order to roughly simulate how keratoconus patients see, we extracted data from the Zernick report of the Pentacam and used a 3D printer to create a camera lens with aberrations. Adjustments were made to match the camera dimensions. Since we can control the aperture of the camera, we can gauge the importance of pupil size in keratoconus. Glare, ghost images, and blurring are significantly reduced as we reduce the aperture. We've done this procedure in 69 eyes with a mean follow-up of 2 years, with a very important improvement in visual acuity. Some patients present halos and a sensation of dark vision under low light conditions, but these are usually very well tolerated. In face of lens extraction in a younger population, it is very important to count with the support of a retinal specialist, who should evaluate the patient preoperatively to assess the risk of retinal issues in the future. IOL power calculation can be challenging in keratoconus, but with few adjustments, it is absolutely possible to be performed. The most important point to remember is, no matter what machine is used for keratometry, no matter what formula, there is a strong tendency towards a hyperopic surprise. The more advanced the disease, the stronger this tendency is. Therefore, we always measure corneal curvature with 3 different equipments and use the flattest value. We also use a fudge factor to add power to the suggested IOL based on mean keratometry. The IC8 pinhole IOL can also be used in this scenario. However, bear in mind that the lowest power available is plus 15. So, in keratoconus, a negative IOL piggyback is likely to be necessary. In conclusion, this new approach may be very effective in the treatment of a specific group of keratoconus patients, especially those with larger pupils. Without even touching the cornea, the modern refractive cataract surgeon may be able to give joy, and those patients may finally overcome despair.
Você nos autoriza a gravar sua história e divulgar ela no formato de vídeo?
Dr. Tabor, it seems that every year the small aperture IOL expands its indications, which started targeting iris deficiency, glare, and irregular astigmatism. Now it's a new treatment for keratoconus. I love the human touch and the empathy in this video. What were your thoughts?
We are truly blessed by the Trindade family of incredible eye surgeons and filmmakers extraordinaire. Father and son have blessed us with these wonderful videos. And this particular video of a small aperture IOL in the face of advanced keratoconus is truly the pinnacle of their work. Every judge that watched this was touched by the compassion for this patient that Dr. Trindade expressed in the video. I truly believe that this small aperture lens is needed for our patients, and the film festival fully supports the development of this lens, so it is available throughout the world for patients who are running out of options for irregularities in their cornea that can be addressed so beautifully by this small aperture intraocular lens. Congratulate Dr. Trindade for his passion, his compassion, and his science.